I'm Dr. Joe Weinman. I'm the president of the SNDS, our local dental society. We have, this is a mandatory class that we're going to repeat in the fall for all of the providers, dental providers in our society. We're also videotaping this event tonight, so it'll be available if you miss it or can't make the next one at our office for the same low price of $95. We have two great speakers with us today. Both of them are our state pharmacists, Dr. Yen Long and Mr. Ray Seiderlinger they're going to be our two presenters today. They're going to go through a prepared presentation, and then I'm sure a lot of people here in the audience have some questions dealing with AB 474, the controlled substance legislation piece that was signed by the governor last session, and that became our law on the 1 January of this year. So without further ado, I'm going to get out of this mic and I'll give it to Yen and let her start.
How's everyone doing tonight? Hungry, which is unfortunate because you guys are probably hangry as well and probably not so excited about this new law. So my name is Yen Long. I'm actually the program administrator for the PNP. So if you call our office, it's probably me or my colleague Janine that answers the call. So I run the PNP for the state of Nevada. I'm also a pharmacist as well. I graduated in 2011. In fact, I actually wanted to be a dentist for a while, but I'm glad I didn't because there's a lot you guys have to do now. Just kidding, I'm kidding. Anyhow, I'm sure some of you, probably all of you, have heard about Assembly Bill 474, AB 474. How many of you have not heard of AB 474? That's good. I'm glad. I'm glad to hear that because there's a lot to this bill. How many of you are wondering why, you're sitting here, you're thinking, I'm a dentist. Why am I here on a Thursday evening having to sit around and listening to the CE when the opioid epidemic is due to those dang doctors, those nurses and PAs? How many are you think yes, one, he is not afraid. A lot of you are. Okay, all right. The thing is, did you know that people are first exposed to opioids after a sports injury or a dental procedure? A study shows, yes, it's true. So a study shows that legitimate use of opioids before high school graduation is associated with a 33% increased risk of misutilizing opioids after high school graduation. A 2011 study in the Journal of the American Dental Association estimates that dentists prescribe 12% of all the immediate release opioids in the United States. And they're only slightly behind family physicians who prescribe 15%. So doctors do prescribe a lot of opioids, believe it or not. In Nevada, we have one of the highest number of overdose deaths, averaging 1 death per day. Because of this, it's crucial for all practitioners and dentists to play a part in curbing this epidemic. All right, so that is what we're going to be talking about tonight. How implementing AB 474 in your practice ensures that you have enough information to prescribe controlled substances safely to your patients to ensure they're not misutilizing it, abusing it, or becoming addicted to these substances. All right, before I go deep dive into AB 474, it's really important to have an overview of why we are where we are today. Why do we have an opioid epidemic? So that is what I'll start off with, and then will be followed by a detailed explanation of AB 474 and how you can implement that in your practice. And then I'm going to talk about the PNP because that's my life. How utilizing the PNP can help you guide your clinical decision and prescribing decisions. Okay, so how did we get to where we are today? We're a nation so reliant on these controlled substances. Why? Well, the United States population makes up about 325 million people. We are about 5% of the world's population, yet we consume 80% of the world's supply of opioids. That's 75% of the world's supply of oxycodone and 99% of the supply of hydrocodone. All right, we're only 5% of the world's population, yet we consume so many narcotics. How did we get to where we are today? Well, we've been using opioids for a very long time. The opium poppy was cultivated in Lower Mesopotamia in 3400 BC. It was known as the joy plant. And since then, there was morphine. that was extracted from opium poppy, utilized in the Civil War. A lot of people became addicted to that. And then there was the synthesis of heroin, and then so on and so forth. But where we are today is the result of the 1970s, 1980s, and 1990s. In 1970s, that was when there were a lot of hippies, right? And they were utilizing a lot of drugs, LSD, heroin, cocaine, psychedelics. So many people were addicted to substances that President Nixon actually declared the war on drugs. That's when you first hear the term coined, war on drugs. He said addiction is public enemy number one. And what he did was he increased federal regulation. That was when the Controlled Substance Act was passed. That allowed for us to categorize these substances into their 5 categories, C1, C2, C3, C4, C5, based on their abuse potential and their medicinal use. All right, after the Controlled Substance Act was the birth of the DEA. DEA was tasked with regulating the use of controlled substances. So after Nixon declared the war on drugs, there was an increased number of basically incarceration rates for nonviolent drug-related crimes. So many people were afraid to use drugs, so many doctors were afraid to prescribe drugs. And that was unfortunate because in 1980s, 1990s, people were undertreated for pain. You have cancer patients, hospice patients who weren't being treated for their pain. So Pain Society said, we need to recognize pain, that this needs to be treated. So in 1996, the American Pain Society dubbed pain as the 5th vital sign. So you're not only assessing the patient's blood pressure, respiratory rate, heart rate, temperature, you also have to assess the patient's pain. Doctors and hospitals were rated on how well they treated patients' pain. So doctors felt a need to prescribe controlled substances, to prescribe opiates for management of pain. And a drug company, Purdue Pharma, took advantage of this. They manufactured OxyContin and MS-Contin, all right? And these are our long-acting release opiates, our narcotics. And they aggressively marketed it to doctors saying that they're not addictive. So doctors felt relief. I'm supposed to treat patients. I'm going to treat these patients with these non-addictive opiates, and everything will be fine. But then there was an explosion of addiction. All right, and then in 2007, I believe, Purdue Pharma actually pled guilty for misleading the public by saying that the product was not addictive. So that is where we are today, the results of what happened when pain was changed to the 5th vital sign, when these medications were advertised as being non-addictive. Oh, let me go through all of this. Oh boy. All right. So as a result of that, from 1999 to 2013, the number of controlled substances prescribed and sold actually quadrupled. There was enough controlled substances prescribed in 2013 where every American adult could have a month's supply of hydrocodone around the clock, every 4 hours. That's everyone in this room would have a month's supply of some kind of narcotics. If I was Oprah Winfrey, that's oxycodone for you, oxycodone for you, everyone in here. Okay? So a lot of people were getting narcotics. A lot of people became addicted to these medications. And then that gave rise to pill mills. Pill mills were really popular in Florida, and they were actually here in Las Vegas as well. Pill mills were essentially pain clinics where doctors will write hundreds of prescriptions a day. They don't actually see the patient. They come in, here's a prescription, and they charge, I don't know how much, $25, $50 for a prescription. And this was really lucrative for the practitioner. And these patients will take it, fill it, because they're either addicted, or they'll turn it around and make a profit off of the actual prescription. An oxycodone 60 milligram tablet can be sold for $60 on the market. If you get 90 tablets, which is a general 30-day supply of that, that's $5,400. A pint of promethazine and codeine, which is a cough syrup that is prescribed a lot for cough, it can be sold for about $1,200 to $2,000 on the street. All right, it is known as a purple drink. Anyone heard that before? You mix it with some 7-Up and then Jolly Ranchers and rap music. No? No one here? Okay, well, it's known as the purple drink, okay? All right, so if you couldn't go to the pill mills, a lot of people doctor shopped, meaning they will go from doctor to doctor to get prescriptions for pain medications so that, they can feed their addiction or sell it on the street. As a result, from 1999 to 2013, we see that the number of controlled substances prescribed and sold quadrupled. We also see a parallel effect, which is in orange, that the number of deaths nearly quadrupled, paralleled this effect. All right. Here is a chart with very similar information. From 2001, 2014, this is from the CDC. 2001 shows that there are about 5,000 deaths as a result of prescription opioids, and 2014 about 20,000, again a fourfold increase. Every day, 91 Americans die from utilizing some form of narcotic, right? And a lot of people think, it's not prescription drugs causing these people to die, it's the street narcotics, our heroin. But out of those 91 Americans, 44 of them, 50% of them die from prescription opioids. And there are countless number of people who go to the emergency room daily for treatment of side effects or misutilizing opioids, all right? 1,000 people every day go to the emergency room. How are we doing in Nevada? In 2015, Nevada had 316 deaths from prescription opioid overdoses. To put things into perspective, Nevada's population size, we're actually ranked number 32 in population size with 3 million people. California has 40 million people. They're actually ranked number one for population size. Texas has 28 million. Then you have Florida and New York around 20 to 21 million people. But we in Nevada, we're 3 million people, ranked 32, yet we are ranked 4th highest for the number of oxycodone prescribed and sold. We're the 4th highest for the number of morphine medications prescribed and sold, and 11th for hydrocodone. We are a state that prescribe a lot of these medications, even though our population isn't even that big. As a result of this, Nevada is ranked number 3 for the number of opioid deaths. All right, with only West Virginia and Utah ahead of us, but we're not far behind. All right, and the reason why AB 474 was passed is because of the fact that we are the 3rd highest state for opioid deaths. It became a huge priority for Governor Sandoval to address this issue. In 2015, he had a bill. It was Senate Bill 459, the Good Samaritan Drug Overdose Act. It actually increased people's access to naloxone, which is a life-saving antidote to opioid overdose. And then in the 2017 legislative session is also the governor's bill. It was passed, and that was AB 474, also known as the Controlled Substance Abuse Prevention Act. I do want to express that although I work for the Board of Pharmacy and the P&P, I did not write this bill, okay? I didn't write it. The Board of Pharmacy didn't write it. We get a lot of hate emails, a lot of hate calls, but I can't change it. I am sorry, but I didn't do it. I am simply here to tell you how to implement it into your practice. I think it's a good law because I see so many people dying from this, okay? But I'm not the person you need to talk to. Talk to your legislators if you want things changed, okay? But what the Board of Pharmacy can do is we can write regulations to clarify any of the things that are unclear in any kind of bill, right? In any kind of statute, we can write regulations to clarify that, but we can't change the meaning of the actual statute itself. So I just want to let you know, I'm not the person that can change it, okay? So talk to your association and talk to your legislators in 2019, okay? All right, Assembly Bill 474, what is it? How will it impact you? All right, it was effective January 1st. It was a 52-page bill, and a lot of stuff is in there, and it can be confusing. So I'm breaking it down, and I'm going to show you how easy it is to implement it, and you're going to think, oh, wow, I was scared for nothing, because it's not that scary. All right, so these are the components, new components to a written controlled substance prescription. factors to consider before writing any controlled substance prescriptions, factors to consider before you initiate a new prescription. What do you do when you prescribe after 30 days, after 90 days, after 365 days? What are your continuing education requirements? And that is why you are here. Mandatory registration use of the PMP, and then enforcement. What happens if I don't follow this? A lot of people want to know, what can I do to get by? You can't get by, all right? I'll tell you that. All right, so new components to a controlled substance prescription. This is very simple to me because I'm a pharmacist, but not so much simple for practitioners. But these are the 4 new components that you must add to all controlled substance prescription. And you may be noticing that pharmacies or pharmacists have been rejecting your prescription because it doesn't have like ICD-10 code or DEA number, things like that. And that's because of AB 474. With new controlled substance prescription, you must add the patient's date of birth. You guys are already doing that, so it's not like a huge thing. You must have your DEA number on there, which a lot of practitioners do already. And if you don't, just add it on to your prescription, okay? You must have an ICD-10 code. To you guys, you probably are familiar with CDT codes, but there's an equivalent ICD-10 code. American Dental Association has those kind of conversions. I know the Dental Board put together a reference that allows, that has all the common CDT codes and what they are in terms of ICD-10 codes. And there's an app too. You can type in whatever you're treating and it'll pull up the ICD-10 code that you would indicate on that prescription. And the 4th item is a day's supply that the prescription is intended to last. A lot of times pharmacists calculate this. You give a prescription that says Norco, 1 POQ4 PRN, right? 1 every day, every 4 hours as needed, right, for pain. You give 30 tablets. To a pharmacist, that's 6 tablets a day. It should last a patient 5 days. We will calculate it as 5 days. But as a dentist, if you think, okay, I expect my patient to start off with 6 tablets a day, but eventually slowly taper off. I want it to last 10 days. And so you can indicate on the prescription that the prescription must last 10 days. And this is a sample of a prescription written with all the correct components. All right, you have to have the date of birth of the patient now, the ICD-10 code, and this ICD-10 code is for low back pain. Please don't use it for your prescriptions. The DEA number, right? And if there are multiple practitioners listed on the prescription, such as here, you do have to indicate which one you are, especially if your signature is illegible. All right? And then the day supply, how long the prescription must last. Okay? Here's just another example of that. Type written out, so it's easier to see. And here are all the components of any controlled substance prescriptions, including the 4 other additional items. These are things that you guys have been doing correctly before, so you won't have to worry about that. All right, so those are the new components of a controlled substance prescription, what you must add. Does that seem really scary, difficult? No, we're good, right? See how easy it is? All right, so before writing any prescriptions for a controlled substance, these things you have to consider. You don't have to document it. You don't have to write it down anywhere. These are things that probably should come intuitively to you, but you know, some doctors don't think about these things, but these are things that you must consider as well, which you probably are already doing when you're writing prescriptions for patients. And you must consider these things where applicable. Some of these things don't apply to you guys, okay? So it says that if the controlled substance prescription, if previously prescribed, is it working as intended and as expected? All right, a lot of you guys are treating acute pain, not chronic pain, where you're repeatedly prescribing to the patient, right? So this wouldn't apply to you because you don't know how it worked before because you've never prescribed it to the patient before. So this isn't something you would have to assess. All right, the second is there reason to believe that the patient is not using the controlled substance as prescribed or is diverting for use by another person? Again, this is when you repeat the prescription, right? You wouldn't know if they're diverting if you've never prescribed to that patient. Does the patient have a PMP report, which stands for Prescription Monitoring Program Report? indicating that the patient is using controlled substances inappropriately or using other controlled substances not as prescribed. So before you write prescriptions for a controlled substance, you must assess the patient's P&P. This is something you have to do. And so if you notice that the patient yesterday went to dentist down the street and got a prescription for hydrocodone, you probably shouldn't prescribe it to the patient again today, right? Especially if they got like a 30-day supply. All right? Does the patient have a history of substance abuse? If they tell you, yeah, I used to abuse, amphetamines and heroin, you may not want to prescribe oxycodone or hydrocodone to them. Maybe you want to do something like ibuprofen or Tylenol. Is there reason to believe that the patient is currently misusing or addicted to the controlled substance? Is there reason to believe that the patient is using other drugs that may be interacting or will interact negatively with the controlled substance that you prescribe? Number early refill attempts or times the patient claimed that the prescription has been lost. Again, this only applies to more chronic management of pain. Does their blood or urine test indicate inappropriate use of the controlled substance? If somehow you gain access to the urine test or their blood test and it showed use of amphetamines and heroin, then it may skew or change whether or not you want to prescribe to the patient, but you may not have that. And any major changes in the patient's health that would affect the medical appropriateness of the controlled substance. So those things are things that you may assess if and when they're applicable and appropriate. And you're probably already doing that. All right, so before you write an initial for a controlled substance prescription, most of you are writing for acute pain. Any of you guys treating chronic dental pain? You. Okay. Oh, TMJ, right? Did I say that right? Okay. All right, so you're doing chronic pain management. All right, anyone else? Okay, a lot of this will apply to you, but a lot of everyone else is going to be very simple. So this is more acute pain management. This is what you have to do before you write that initial prescription. You must have a bona fide relationship, meaning you must have assessed the patient, treated that patient. That's what you're doing already. Hopefully you're not just writing prescriptions to Joe Schmo down the street and never having seen them, right? This is just common things to do. And this is not a new law. This has always been the law that you have to have a bona fide relationship with a patient. The thing is, it had to be specified in the bill because people were writing prescriptions for people that weren't their patient. That's the reason why. Right? You must establish a preliminary diagnosis and treatment plan. Patient has dry socket. Plan to treat them for 2 days on hydrocodone. Something like that, okay? Perform a patient risk assessment. And the reason why it's green is because there are components to the patient risk assessment I want to talk about. Obtain and review the patient's P&P report. Discuss non-opioid treatment options because people may want to avoid the risk of becoming addicted to these substances. There are other drugs possibly that can do the job. So discuss those treatment options with the patient. And the reason why that's so important is because a lot of patients, when this bill was being discussed over, a lot of patients testified and they said, if I knew how addicting these drugs were, I wouldn't have taken them because I've lost my family, my job, my life. So it's important to give them alternatives. If you decide to write that prescription for the patient, right, it must not be for more than 14 days and must not be for more than 90 morphine milligram equivalents, MME. Okay, and then you also must complete an informed consent. It sounds like a lot, but these things you're naturally doing. I believe, I hope you're naturally doing some of these things. But the informed consent is in green because there are components that you have to do within the informed consent. All right, a lot of you guys are probably thinking, what is 90 MME? What does it mean? How do I limit it to 90 MME? So morphine milligram equivalents is what we do when we're managing patients on pain medications and they're in chronic pain. A lot of pain doctors will basically